What is up, you guys? We are back with another video here. We're talking about the anatomical structures of the oral cavity, the pharynx, and the larynx. We're going to learn how to understand what those anatomical features are and how we can apply those into our clinical scenarios. Whether this is your first time assessing a patient or you're trying to refine your skills, this video is for you. Let's dive in. All right, you guys, so we have talked about a number of different structures already. We've gone into the thorax, we've talked about the mediastinum, we've talked about the pleura, we've talked about the ribs and how they operate, the sternum and its purpose, and we've also gone into the nasal cavity. So let's move into the oral cavity, where we're going to start talking about some of the different structures that we have that we see in place here. So here in the oral cavity, we have a number of different structures, but really the oral cavity is a secondary point that we can use to get air into the tracheobronchial tree. So we know that the nose is our primary source, but when do you think that we would use the oral cavity for getting air into the tracheobronchial tree? And what principle do you think is at play to help patients in getting that breath in and using the oral cavity as that accessory site? I want you guys to think about that. Why would we use the oral cavity? So as we go through and we talk about some of these different structures here, you can see that there's an outline right here, and this would be what we call the hard palate. The hard palate is part of the roof that makes up the oral cavity. It's made up of the maxilla bone. So the maxilla bone is the floor of the nasal cavity, but we see it's the roof here of the oral cavity. On the back side of this, we have the soft palate. The soft palate is actually, it's mobile. It moves up into the nasal pharynx and down into the oral cavity. And on the posterior side of that, we have the uvula. The uvula is the hangy downy thing that we see so many cartoons kind of using as a punching bag. But it has a purpose as kind of a gatekeeper. It will monitor how much air is coming into the pharynx. It'll monitor fluid or drinks that are being passed through, liquids that are being passed through the oral cavity, also food. So it is monitoring a number of different things as those objects are being passed into the pharynx. So the soft palate, like I was saying, it actually moves up into the nasal cavity here. It has the ability to go mobile, but what it also does is it can close off the nasal pharynx by moving up during swallowing, sucking, or even blowing. And we use this during our speech, and singers use this so well. Freddie Mercury, who was the lead singer of Queen, he could use this soft palate to reach a lot of those notes that so many other people couldn't reach. He was special when it came to manipulation of that soft palate. And it is actually made up of stratified squamous epithelium. The uvula, like we said, it is that gatekeeper to help monitor the airflow that's coming through it, food particles, and also any fluids that are going through. On the lateral sides of the oral cavity, we have our cheeks, and then on the floor, on the floor here, we have the base, which is made up of the tongue. And the tongue has so many different functions. We use it for mechanical digestion. We use it for taste. We use it for our speech. It helps us form the letters K, D, and T. And in the posterior side, on the back side of the tongue, there's a lot of sensors at the back side of the tongue that we need to be mindful of when we are passing instruments or even endotracheal tubes or suction catheters back there, because that is where we get our gag reflex from. So we've got to be aware of when we are placing instruments back here, when we're operating or working within the posterior oral cavity, that we can stimulate a gag for these patients, and this could be dangerous if those patients are unconscious or under anesthesia, and that can lead to a gag, which could lead to retching, which could then lead to emesis or vomit going into our unprotected airway at that point. So we've got to be careful of manipulating that back side of the oral pharynx or the posterior tongue, because we put that patient at risk for foreign bodies going into the trachea. Some additional functions of the oral cavity: it doesn't work really as well as the nose does, but it has the function of humidification and heating. So the saliva that is in your mouth, that is moisture, that is water that's in your mouth, that will humidify air as it goes into the trachea. We know that the salivary glands are kind of that first component of digestion. It binds to the food that we have, so it creates this mass of food. When it creates that ball or that mass, we call that a bolus of food. So it plays a key part of digestion. As you can see here, we have palatine tonsils on that posterior oral cavity on both sides here on the lateral portions of that posterior oral cavity. Those are vascularized lymphatic tissue. And we remember that the lymphatic system is, we see that it's the waste management system for when a patient may have an infection or a surplus of fluid from that cascade effect when the white blood cells show up to an infected site. Lastly, we see here in the reflexes that those are used to protect the lower respiratory tract from foreign bodies during swallowing. So a lot of impact that the oral cavity has. And one of the things that we have to be careful of is when patients are unconscious or whenever they're under anesthesia, the protective mechanism, these reflexes, do not work nearly as well as they do for conscious patients. So if we have somebody that is unconscious, whether that's them being asleep or they've had some sort of traumatic injury or they're under anesthesia, that can lead to what we call aspiration. Aspiration is not like I'm aspiring to be something. It is more of, in our terms, in a pulmonary terms, that is talking about a foreign body going into the pulmonary system or the tracheobronchial tree. So we want to avoid aspiration, because if we do aspirate even saliva, we know that saliva has bacteria that's used to break down that food. And if that bacteria gets into our respiratory tract, that can lead to an infection, lead to a pneumonia, and lots of additional therapies and work and infections that can fall in line whenever we have that aspiration. So these reflexes, they're very protective in nature. So what I want you guys to think about is, when would you think of perhaps a traumatic situation when this reflex that's designed to be protective could actually go against the patient? So there's a specific time that I'm thinking of that this could take place. So what do you think? When could these reflexes work against us? Moving on into the pharynx, this is an area that's made up of three parts: the nasal pharynx, the oral pharynx, and the hypopharynx, or the laryngeal pharynx. So the laryngeal pharynx can also be called the hypopharynx. So we're looking at this area back here. We're looking at this area right here, that is the pharynx. So back behind the oral cavity, but above the trachea. So that is what we're looking at. The pharynx is the posterior portion of the nasal cavity and the oral cavity openings. It's made up of stratified squamous epithelium, and it's got the three parts like we were talking about: the nasal pharynx, the oral pharynx, and the hypopharynx, or the laryngeal pharynx. So we've talked about the nasal pharynx before, but just as a recap, this is the posterior nasal cavity to the tip of the uvula. So we're looking at this area right here that we're going to call the nasal pharynx. It's made up of pseudostratified ciliated columnar cells, and we have the adenoids that are there that are part of the immune system. We also have the eustachian tubes that are used to equalize the pressure of the eardrum or the tympanic membrane. The oral pharynx, this is the posterior region of the oral cavity. So we just left this area and now we're moving into this green area, the oral pharynx, the posterior area behind the oral cavity between the uvula and the upper epiglottis. There's a set of tonsils that are on the lateral walls, and these can be chronically swollen. And when they become chronically swollen, they're at risk for obstructing the airway. And these can swell so much, they can have so much excessive swelling. And if that happens time and time and time again from repeated throat infections or sore throats or an ear infection, this can lead to the removing of these tonsils or a tonsillectomy. So that is an important site right here where we can have tonsils being removed from repeated infections or repeated excessive swelling from those infections. Right here, you guys see there is kind of a little groove right there. I want to kind of highlight that just a little bit more. Right there. That area right there is called the vallecula. The vallecula is really important because this is the site in which we would place a laryngoscope, the blade of a laryngoscope in this area, or we would locate this area and get on the other side of the epiglottis so that we could pull this anatomy upwards and out of the way so that we could access the vocal cords right. So the vallecula is here. The epiglottis is here. If I pull all of that anatomy up whenever I'm intubating the patient, I now have direct sight into the vocal cords for an intubation or a placement of an advanced airway. So the oral pharynx has a very important structure there with the vallecula or locating the epiglottis to move that anatomy out of the way so that I get a direct sight into the vocal cords, into the trachea. That is an important landmark for intubation. As we move on into the hypopharynx or the laryngeal pharynx, this is below the oral pharynx. So this structure right here is the epiglottis. This area right here, this opening, this fold, this crevice right here is the vallecula. So you have the epiglottis and the vallecula right here, both very important pieces for placing an advanced airway or intubation. So when we look at the hypopharynx, we have a space right here between the epiglottis to the vocal cords. This area is our hypopharynx or the laryngeal pharynx. It's made up of non-ciliated stratified squamous epithelium. So we have this area that has different cellular structure in that area. We also have the 9th and the 10th cranial nerve in this area. The 9th cranial nerve is the glossopharyngeal, and the 10th cranial nerve is the vagus nerve. And when those two get working together, they have what's called the pharyngeal reflex. That's just a fancy way of saying they have a gag reflex, or that's the swallow working. Depending on which way those nerves are directing the muscles to go, one will lead the food or the liquid down into the esophagus. The other one is projecting the food or bile up out of emesis, up out of the esophagus, back the opposite way. So that we call the pharyngeal reflex, which is a gag or a swallow reflex. Again, this area is used to help avoid an aspiration. We have a number of different structures that are designed to help protect the airway. They're designed to help protect the tracheobronchial tree. And this area really holds a lot of tension to anatomical structures while we are sleeping. So when we have patients that are asleep, or when we do go to sleep, you get those structures that start to kind of tend to relax, and they don't hold that tension nearly as well as whenever we're awake and we're conscious. So when we're unconscious and we are maybe anesthetized, we have less tension on these structures, on these muscles, that can lead to a hypopharynx collapse. So when that happens, that can lead to a partial or a complete obstruction, and we could see this with patients who are asleep. So what do we call the disorder or the condition when we have patients that when they fall asleep, you have an obstruction of their airway? So like the nasal pharynx, the hypopharynx has the ability to shift. It has the ability to move. And what I like to call is it's the shapeshifter, kind of like Maui in Moana. It can shift its shape to be that protective mechanism, but it also helps with phonation, with speech, and that protective mechanism when we are swallowing. So again, the hypopharynx can have some dysfunction, and we can see that when we have unconscious patients or sedated patients or patients that have anesthesia, that can lead to its dysfunction and lead to an obstruction of the airway. Going into the larynx is also known as the voice box. It has a number of different functions, but this is below the hypopharynx. This is below the hypopharynx, and it leads into the opening between the pharynx and the trachea. So this is that area between the pharynx and the trachea. One of the major functions of the larynx is to ensure that the airway, or the flow of air from the nasal cavity or the oral cavity, gets into the lungs and out of the lungs efficiently. So it kind of has a gatekeeper property as well, where when you take a breath in, the opening of the vocal cords kind of open up, and then on exhalation those things close down. So we have movement in this area each and every breath. Part of the larynx or the voice box's responsibility is to open up the passageway into the trachea and close it down when we are exhaling. One of the other things that it does is it allows us to perform what's called a Valsalva maneuver. A Valsalva maneuver, by definition, is a forced exhalation against a closed glottis. So when we would do this, when would we instruct somebody to do this, and how would we do that? So there's a number of different things that we can do. We can ask the patient to bear down like they're having a bowel movement, or we can pull the plunger out of a syringe and have them blow into it like they're trying to blow up a balloon. And what that does is it creates this Valsalva maneuver, and we see that that pushes, or that innervates, or that initiates a response from the vagus nerve, causing a vagal response, which would lead to a decrease in their heart rate and decrease in their blood pressure. And sometimes we do this in situations where patients, or they're in a arrhythmia called supraventricular tachycardia. So when you learn ACLS and when you learn arrhythmias, SVT is one of those that you learn. And a way that we can try to treat that is to have the patient do what's called a Valsalva maneuver. Again, that is a forced exhalation against a closed glottis. So here we see that this, again, the larynx is serving, one of its purposes is to protect. It's the last form of protection that we have before that foreign body can get into the windpipe or into the tracheobronchial tree. So we have a number of different mechanisms that we try to call upon to protect the lower airway. And the larynx is our last line of defense for protecting from aspiration. And then finally, the voice box is where we get the generation of sound for speech or phonation. So we have a number of different functions when it comes to the larynx. Now, let's kind of break down the anatomical features of the larynx. It is made up of 9 different cartilages that make up the larynx. 3 of them are singles and 3 of them are double cartilages or paired cartilages. So the pairs end up being 6 total cartilages and the singles end up being 3 for a total of 9. So we have the thyroid, the cricoid, and the epiglottis all making up those single cartilages. And when we look at the thyroid cartilage, this is named after the thyroid gland that sits connected to the thyroid cartilage, also known as the Adam's apple. The Adam's apple, we can find that, we can palpate that whenever we are inspecting our patients. It's a V-shaped cartilage that the uppermost portion of the larynx. When we look at it, it is connected to the hyoid bone. So the hyoid bone is special because it is the only bone in the body that is not connected to another bone, but it's connected to the thyroid cartilage here through this thyroid membrane that we can see right here. So the thyroid membrane connects the thyroid cartilage to the hyoid bone. Again, the significance of the hyoid bone is it's the only bone that is not connected to another bone. Moving on to the cricoid cartilage, this is a signic ring-shaped cartilage. It is the only cartilage that is a full ring when it comes to the airway, when it comes to the upper airway. It is on the posterior wall of the thyroid cartilage, and in infants, this is the most narrow portion of the upper airway. When we move into the epiglottis here, this is a spoon-shaped, or some say that it's a leaf-shaped cartilage that is about 2.5 centimeters long, 2 to 4 centimeters long, 2 to 3 centimeters wide, and about 2 to 5 centimeters deep. And it prevents liquids and foods from entering into the respiratory tract, and it seals tightly with the thyroid cartilage whenever patients are swallowing. Now, when we talk about swallowing is a complex series of muscular contractions, and we really lean on our speech therapist to talk to them about all of the steps that take place just for a swallow to happen. And we see that the thyroid cartilage moves up and the epiglottis will actually move down, creating that tight seal to protect the trachea so that the food or the drink can go into the esophagus. So we have the epiglottis, the hyoid bone, the thyroid cartilage, and the cricoid cartilage that is here below the thyroid cartilage. So moving on to the paired cartilages, we see that there are 3 paired cartilages. Again, the pairing of them make up 6 total cartilages, along with the 3 individuals, making a total of 9 cartilages that make up the larynx. So we have the adenoids, we have the cornicates, and the cuneiforms. All of these cartilages play a role with manipulating and moving the vocal cords. So we have a 3-sided pyramid shaped here, and then we have these other 2 cartilages that are used in conjunction with the adenoids. And like I said, they move and they operate the vocal cords. The true vocal cords are actually attached to the adenoid cartilages, and these are in the posterior portion of the thyroid cartilage. Again, these are paired folds. These are made up of connective tissue and muscle tissue, and they're covered with a mucous membrane. They are really bad at lymphatic drainage, and they are susceptible to inflammation and swelling that can lead to airway obstructions. But they do play a role in vocalization with our true vocal cords. The false vocal cords are located superiorly and laterally to the true vocal cords. Again, they are a pair of folds that play no role. These actually play no role in vocalization. And the cuneiform and the cornicate These are supportive. They're supportive soft tissue on either side of the vocal cords. Now, we talked about during inspiration and exhalation how the true vocal cords will open up during inspiration and then close during exhalation. Now, that opening that we see between the vocal cords is actually called the glottis. So this right here is the opening between the vocal cords that gives you access to the trachea. In adults, this is the narrowest point of the trachea. During swallowing, the vocal cords close to protect the tracheobronchial tree. There is actually a joint between the cornicate and the adenoid cartilages that allows the adenoid cartilages to rotate. And if that thing gets damaged, it can lead to vocal cord paralysis. Now, if the vocal cords get paralyzed, now that last line of defense that will open and close, that will close during swallowing, they just stay open the whole time. So then that patient is at risk for aspirations and additional pneumonias. So we have to be aware of a lot of these different cartilages and these joints that are protective in nature for the lower respiratory tract. The last thing here is the larynx. It can actually have spasms. It can have a reflex that temporarily closes the airway. It can cause laryngeal spasms, which is a reflex to being stimulated. So we can have laryngeal spasms as well. And the larynx muscles, these are innervated or they're stimulated by the vagus nerve. What cranial nerve was that again? The vagus nerve is the 10th cranial nerve. That's right. And it is important that we recognize that the 10th cranial nerve is the impulses that we get for speaking, for speech, and also for swallowing. If we have injuries to the 10th cranial nerve, it can lead to the inability to swallow correctly, difficulty with speech, and ultimately airway obstruction from those vocal cords staying shut. So the next thing here, you guys, is we're going to get a couple of really good pictures when it comes to the larynx. So we have a depiction here of the trachea, or the opening into the lower airway. That opening is called the glottis. You have the cuneiform cartilage, the adenoid cartilage, which is attached to the true vocal cords, and the cornicate, which are all part of those paired cartilages that we see in the larynx. You also have your true vocal cords that are here. These are the whitened areas of the larynx, and then the false vocal cords, which are attached to the lateral and anterior portion of the true vocal cords that can move or are attached to your cuneiform, your adenoid, and the corniculate cartilages that help manipulate and move the vocal cords and the glottis. You can see up here you have the epiglottis, and behind that, this area right here is the vallecula. Those are, again, important landmarks with intubation. Here you see that the glottis is wide open. You have a trachea that is wide open. This would be if this image was flipped over and the epiglottis is here on the bottom, the vallecula would be there. You have your vocal cords that are here. So this patient, let me ask you this, if this airway is open like this, is that patient taking a breath in, or are they taking a breath out? The last thing that I want to show you guys is a breakdown of the different epithelium that we have in our nasal cavity and the oral cavity. So you have non-ciliated stratified squamous epithelium, and then you have the pseudo-stratified ciliated columnar epithelium in the nasal cavity and in the oral cavity. So in the nasal cavity closest to the nose, this is the non-ciliated area. Your oral cavity is non-ciliated down to the larynx is all non-ciliated, but behind the nasal cavity, Before the nasal pharynx, you have the pseudo-stratified ciliated columnar. And then once we move below the glottis, we have the pseudo-stratified ciliated columnar epithelial cells. Lots of important structures when it comes to the oral cavity. Lots of importance when it comes to the epithelium that is in those areas. And next, we're going to move into the lower airway. Thanks you guys so much for watching my video. Remember, mastering these anatomical functions and their features and what happens when they become dysfunctional is going to be essential for your clinical rotations and assessing those patients who love throwing curveballs at you. Stay focused, keep practicing, you'll be ready to provide excellent patient care. And be sure to like, subscribe, leave me a comment if there's something that you want me to go over. Be sure to leave those in the comments and hit that notification bell so you can be the first one to get my tips, tricks, and insights for future videos. And you can find me on any of the social medias. You can even reach out to me personally to my Gmail, jjthert@gmail.com. Looking forward to seeing you in the next video.